Welcome to my YouTube channel, where we continue our exploration of pediatric dentistry. In part 2 of our series, we venture deeper into the intricate world of pulp therapy in primary dentition. Join us as we unravel the mysteries surrounding essential procedures such as Hall crown, indirect and direct pulp capping, DPC, Pulpotomy, and Vital Pulpectomy. From understanding the indications for each treatment to mastering the techniques involved, we provide comprehensive insights to enhance your understanding and proficiency in pediatric dental care. Don't miss out on this enlightening journey as we navigate through the complexities of pulp therapy, equipping you with valuable knowledge and strategy to elevate patient outcomes and promote excellence in oral health care. Subscribe now and embark on this transformative odyssey with us. Pulp therapy in primary teeth. Goals: prevent extension of dental disease and restore damaged teeth to healthy function. Endodontic procedures offer an alternative to extraction for pulpally compromised primary teeth. Failure to treat carious processes or refer to a provider who can treat them is opportunity. Disadvantages of unplanned extractions: loss of space, increasing the chances of malocclusion. Reduced masticatory function, especially posterior teeth. Psychological disturbance, especially with anterior teeth. Extraction can cause future dental anxiety. Assessment for pulpal treatment. Clinical history, pain and symptoms from the tooth. Clinical assessment: presence of abscess, mobility, swelling, tenderness to percussion, restorability of the tooth, extent and site of caries. Radiograph assessment: root length, perifurcational radiolucency, internal resorption. Pulpal response to caries progression. As caries progresses, pulpal tissues mount a protective response, including laying down hard tissue and tertiary dentine, and inflammatory changes. Inflammatory changes extend from odontoblasts adjacent to the carious lesion to the pulp horn, coronal pulp, and radicular pulp. Inflammatory process in primary teeth pulp is similar to permanent teeth. Proximal caries may show more widespread inflammation at an earlier stage. Assessment of pulpal health requires careful history, thorough clinical and radiographic examination. Clinical and radiographic signs may appear only after pulp is infected and non-vital. Histological studies provide insights into pulpal status as caries progresses. Studies. Early 1970s, over 50% of primary molars with loss of marginal ridge had irreversible pulp inflammation. Recent work: most teeth with proximal caries involving less than half the marginal ridge had pulp inflammation, often visible within the coronal pulp. Inflammation may develop at an early stage of proximal carious attack, but reversibility is uncertain. Treatment options for the inflamed pulp in carious primary teeth. Extraction: if all caries cannot be removed, or if there is a risk of infection, extraction may be necessary. This is especially true for patients at risk of endocarditis or immunocompromised individuals. Hall crown or no caries removal. The Hall technique or no caries removal approach relies on achieving an excellent coronal seal. If successful, inflammation is reversible, and the pulp can repair itself. This technique requires accurate assessment of pulpal health. Indirect pulp capping, IPC. IPC is akin to stepwise excavation in permanent. It involves gentle excavation of softened dentine on the pulpal floor without exposing the pulp. A thin layer of setting calcium hydroxide cement is then placed to destroy any remaining microorganisms and promote the deposition of reparative secondary dentine. The tooth is then restored, typically with a stainless crown. However, IPC should be carefully considered for very deep proximal cavities in primary molars, as deep proximal caries may cause more widespread inflammation compared to occlusal caries of the same depth. These treatment options should be chosen based on thorough evaluation of clinical and radiographic findings to a most appropriate approach for each case. Direct pulp capping, DPC, in the primary dentition. Direct pulp capping involves applying a medicament directly onto the exposed pulp tissue. In cases where the pulp is already inflamed prior to clinical exposure, DPC has a poor success rate. Applying a medicament in an area of inflamed pulp tissue is less likely to stimulate a reparative response. Due to its low success rates in inflamed pulpal tissue, DPC is not recommended in the primary dentition. Instead, techniques like indirect pulp capping, IPC, and the Hall technique are preferred, as they rely on an accurate diagnosis of pulpal health. Vital pulpotomy in primary teeth. A pulpotomy involves the removal of the inflamed coronal pulp tissue while preserving the intact radicular pulp tissue. The success of a pulpotomy depends on accurately assessing the health of the radicular pulp after removing the coronal pulp. Persistent bleeding after coronal pulp removal indicates inflammation in the radicular pulp, necessitating alternative treatments like vital pulpectomy or extraction. Ferric sulfate is the preferred medicament for pulpotomy, as it effectively controls bleeding by forming a ferric ion protein complex. Ferric sulfate should be applied onto the pulp stumps for 15 seconds, with additional applications if bleeding persists. Concerns about ferric sulfate potentially masking inflammation in the radicular pulp have been raised, prompting the exploration of alternative materials like mineral trioxide aggregate, MTA. Following pulpotomy, the coronal pulp chamber is sealed with materials like zinc oxide eugenol, MTA. Restoration with a stainless steel crown immediately after pulpotomy is recommended to optimize the coronal seal and ensure long-term success. Follow-up after pulpotomy. Clinical criteria for success. Absence of symptoms. No abscess or draining sinus. No excessive mobility or tenderness. Retention of the tooth until natural exfoliation. Radiographic criteria for success. No evidence of bone loss in the furcation region. Absence of internal resorption, which indicates chronic inflammation. Treatment is only indicated if resorption extends to the external root surface or signs/symptoms of infection develop. Vital pulpectomy. Indicated when inflammation extends into the radicular pulp. Success rates are excellent. Technique similar to non-vital pulpectomy, but with the remaining inflamed radicular pulp being extirpated first. Disinfection phase duration can be shortened as no infection is present in the canals. Requires excellent behavior management techniques due to longer procedure time. Can be reserved for strategic teeth or situations where orthodontic considerations require retention. In cases of loss of patient cooperation or hyperemic pulp tissue, letter mix dressing may be left in situ for a couple of weeks before proceeding with extraction or vital/non-vital pulpectomy. Management of non-vital and abscessed primary molars, pulpectomy technique. Indications for retaining non-vital primary molars. Orthodontic reasons. Medical conditions where extraction is not feasible, e.g., severe hemophilia. Parental refusal for extraction. Procedure overview. Pulpectomy involves accessing the root canal system, disinfecting, and obturating with an appropriate material. Preferred material. Pure zinc oxide, eugenol due to its resorbable nature and ease of removal during root resorption. Root canal anatomy. Lower primary molars, 2 mesial, mesiobuccal, mesiolingual, and 1 or 2 distal root canals. Upper primary molars, 3 root canals, mesiobuccal, distobuccal, palatal. Clinical follow-up with yearly periapical radiographs. Indications of success. Clinical, alleviation of acute symptoms, tooth free from pain and mobility. Radiographic, improvement or no further resorption of bone in the furcation area. Indications for non-vital pulpectomy, non-vital or infected primary molars or incisors requiring maintenance in the arch abscessed primary molars. Radiographic evidence of furcation pathology. Tooth is restorable with at least 2/3 of root length remaining. Pulp treatment of primary incisors, pulpotomy, vital pulpectomy, and non-vital pulpectomy techniques applicable. Parents increasingly reluctant to extract upper anterior teeth. Pulpectomy indicated for caries or traumatized primary incisors with pulp exposures or acute/chronic abscesses. Treatment of a child with high caries rate. Prevention as priority. Establishing a good preventive regime is crucial for children with a high caries rate. Prevention should be prioritized, but restorative treatment or extraction of decayed teeth may also be necessary. Comprehensive treatment plan. Develop a visit-by-visit treatment plan addressing preventive and restorative care. Focus on both prevention and restoration to achieve optimal results. Consider the child's cooperation, extent of decay, and motivation of both child and parents. Findings from studies. Studies show that only a small percentage of caries risk children do not develop further caries without a comprehensive preventive regime. Older children with more caries and less frequent toothbrushing are at higher risk of developing further caries. Initial treatment steps. Conduct initial treatment including temporary restorations, diet assessment, oral hygiene instruction, and fluoride treatments. Use serial plaque scores to monitor compliance with the preventive plan. Immediate treatment for acute cases. In acute cases with severe signs/symptoms, e.g., pain, abscess, facial swelling, immediate treatment is necessary. This may involve extractions or even a general anesthetic in young children to prevent future painful episodes. Comprehensive restorative treatment. Once rampant caries is under control, undertake comprehensive restorative treatment. Aim to retain primary dentition using appropriate methods and ensure the child is pain-free, motivated for oral care into adolescence and adulthood. Key points. Vital or non-vital pulpectomy should be considered to preserve primary teeth that cannot be treated by other means. Both primary molars and incisors can be treated with a pulpectomy technique.